What's up, everyone? It's Miles here from bootcamp.com, and today in pulmonology, we're going to be going over pulmonary edema. So before we begin, if we just take a look at this diagram over here, pulmonary edema is essentially fluid collection within the alveoli. And this is in contrast to things like pleural effusion, which we'll be talking about in future videos, where we have fluid accumulation outside of the alveoli in the pleural space. So first, let's begin by discussing some pulmonary edema basics. The main mechanism that you really want to think about as the cause for pulmonary edema is an increase in the hydrostatic pressure inside the pulmonary capillaries. So if we just take a look at this drawing of a vessel here, if we have very high hydrostatic pressure inside the lumen of the vessel, this can cause fluid to be pushed outside of the vessel into the surrounding alveoli. And so we have that here in the text. The fluid will be pushed out of the pulmonary capillary and it will start to collect within the alveoli. Now, one of the main high yield pathologies that will result in a high hydrostatic pressure within the pulmonary capillaries is left heart failure. So if you can recall from our video on pulmonary hypertension, when we discussed pulmonary arterial hypertension, we said that there was vascular change in the pulmonary arteries here, and that resulted in hypertension in the pulmonary artery, which subsequently stressed the right side of the heart. Whereas in the case of pulmonary venous hypertension, we said one of the main causes was left heart failure. And this is because if we have left heart failure, then blood is going to start to back up in the pulmonary veins and then into the pulmonary capillaries, the pulmonary arteries, and also the right side of the heart. Now, when we have involvement of the pulmonary capillaries from left heart failure, this is going to increase the hydrostatic pressure in the pulmonary capillaries, and this is going to cause fluid to be pushed out and start to collect within the alveoli. So just going back to the text here, if we have left heart failure, this means that the left ventricle will not be contracting as well anymore. And as a result, it will not be pushing blood forward. And so blood will start to back up in the left ventricle, and the pressures in the left ventricle and left atrium will start to get very high. So in left heart failure, we will have high left heart pressures. And as a result, the blood will now start to back up in the entire pulmonary circulation, and then we will get very high pulmonary hydrostatic pressure. Now, there's another phenomenon that occurs in left heart failure, and this is called positional nocturnal dyspnea. And if we just break it down, this means that in a certain position, usually at nighttime, we will have trouble breathing. And so what's occurring is that when a patient is upright, then a lot of the blood due to gravity will be draining to the legs. Whereas when a patient goes supine, like when they're in bed, then this is going to increase the venous return to the right side of the heart. So if we just take a look at this diagram again over here, if we increase the venous return to the right side of the heart, and then that will subsequently go to the left side of the heart. But if we have left heart failure, we will not be pushing that blood forward very well. And so again, that blood will start to back up into the pulmonary capillaries. And once it backs up into the pulmonary capillaries and increases the hydrostatic pressure in the pulmonary capillaries, again, the fluid will be pushed out and start to collect in the alveoli, causing pulmonary edema. So this is really the concept behind positional nocturnal dyspnea. When we are lying flat at nighttime, we will be increasing the venous return to the heart, and because we have left heart failure, this is going to back up into the pulmonary circulation, and this will cause an increase in the pulmonary hydrostatic pressure in the pulmonary circulation, which will subsequently result in pulmonary edema, which is going to cause the dyspnea. Another thing that we can see in left heart failure is something called heart failure cells. So just taking a look again at this diagram over here, recall that within the alveoli, we have these macrophages called dust cells. Now, when we say that blood is backing up from the left side of the heart and increasing the hydrostatic pressure in the pulmonary capillaries, and subsequently we have fluid being pushed out from the capillaries into the alveoli, this fluid that we're pushing out into the alveoli is a transudate. So when we have fluid moving out of a vessel due to high hydrostatic pressure, it's usually going to be in the form of a transudate. Whereas when we have fluid moving out of a vessel due to vascular inflammation, where we have actually a change in the permeability of the vascular wall, now we're going to allow bigger things to leave the vessel like proteins. And this is called an exudate. And we could see this in things like pneumonia or ARDS. So in the case of of pulmonary edema caused by left heart failure, we're not actually changing the permeability of the vessel wall, so we're really only allowing a transudate to escape through the vessel. However, occasionally the hydrostatic pressure can get so high that a red blood cell might be able to squeeze out of the vessel wall. So again, just taking a look at this diagram here, if we have a red blood cell that has managed to squeeze out of the pulmonary capillary and enter the alveoli, what's going to happen is that red blood cell is going to be engulfed by the alveolar macrophage. And once this red blood cell is engulfed by an alveolar macrophage, it will subsequently break down and release its iron-containing compounds in the form of hemosiderin. And so what we're going to see are these hemosiderin-laden macrophages within the alveoli, which essentially contain engulfed extravasated red blood cells. So if we just take a look at this histology image here, we can see this border that goes all the way around. This is the border of an alveoli, and these white spaces here that are on either side of this border just represent air spaces. And if we take a look inside the alveoli, we can see this kind of brown or bronzy looking cell right there. That is a macrophage that has engulfed a red blood cell, and now that red blood cell has broken down into hemosiderin, and so we call it a hemosiderin laden macrophage, or in other words, a heart failure cell. And heart failure cells are usually a sign that there's been chronic pulmonary edema or chronic pulmonary congestion, usually caused by left heart failure. Now, another thing that can increase the hydrostatic pressure within the pulmonary capillaries and result in pulmonary edema is a drug called mannitol. So mannitol is essentially an osmolyte that we can add to the blood, and one of its main uses is in the treatment of cerebral edema. So in cerebral edema, we have all of this fluid in the extravascular spaces of the brain, and so how we can treat this is we can increase the osmolarity of the blood in the form of adding mannitol, and this is going to essentially draw fluid out of the brain, as that fluid is going to be more attracted to the blood as it has a higher osmolarity. However, a side effect of mannitol is that not only is it going to be drawing fluid out of the brain to treat cerebral edema, but it's going to be drawing fluid out of all extravascular spaces of the body, and as a result, it's going to greatly increase the blood volume. And as we greatly increase the blood volume, this is also going to greatly increase the hydrostatic pressure in the pulmonary capillaries. Now, just taking a look again at this vessel over here, now that we have all of these osmolytes in the blood, this is creating a force to draw fluid from the extravascular space into the vessel. However, the pulmonary capillaries are very thin and tend to be a little leaky when the hydrostatic pressure is very high, and so even though we have this force to draw fluid into the blood, the high hydrostatic pressure from the increased blood volume due to mannitol outweighs that force, and so as a result, we're actually going to see fluid leak out of the pulmonary capillaries and start to collect in the alveoli in the form of pulmonary edema. And so in summary, mannitol can treat cerebral edema. However, because it greatly increases the blood volume, it has the side effect of causing pulmonary edema. So like we discussed, the main mechanism in which we see pulmonary edema is an increase in hydrostatic pressure of the pulmonary capillaries. And we said one of the main things was left heart failure, but this can also be caused by mannitol. Another way that we can get pulmonary edema is if we have a decrease in the oncotic pressure. So taking a look again at this blood vessel here, oncotic pressure in a way is kind of similar to osmolarity. So we have these proteins now within the blood vessel, and these proteins create a driving force to bring fluid into the blood vessel. So it's similar to osmosis where we talk about solutes, but in this case we're talking about oncotic pressure due to proteins. And really the main protein that you want to think about for oncotic pressure is albumin. And so if for some reason we're not producing enough albumin, or we're losing albumin through the urine, so we're losing these protein concentrations, now the blood essentially won't be able to hold on to fluid as well, and so as a result we're going to start to see fluid leaking out of vessels. And two classic conditions where we see a decrease in the oncotic pressure is, first of all, nephrotic syndrome, where we're losing albumin in the urine, And second of all, liver failure, where we're not producing as much albumin, because recall that albumin is produced in the liver. So like we said, in both of these cases, we're going to have a decrease in the amount of protein in the blood, and this is going to cause fluid to leak from the pulmonary capillaries and collect in the alveoli. So now we talked about what causes pulmonary edema, but now let's talk a little bit about what happens when you have pulmonary edema. So first of all, we're going to see a VQ mismatch or a shunt, and this is because if we just take a look again at this diagram over here, if we have fluid that has collected within the alveoli, this is going to impair the alveolar capillary interface. And so as a result, when we have venous blood coming from the pulmonary artery and it enters into the pulmonary capillaries, it will not be able to undergo gas exchange very well, and so some of it will just shunt right on by into the pulmonary veins. Next, we're also going to see a decrease in the DLCO, or the diffusion capacity of the lungs, and this is essentially for these same reasons. The alveolar capillary interface is disrupted, and so again, just taking a look at this diagram, when we have gases coming into the alveoli, it will not be able to diffuse as well into the pulmonary capillaries because it's being blocked by that alveolar fluid. And lastly, we can see a decrease in the lung compliance. The lungs will be harder to expand. And one of the main reasons behind this is the fact that we're getting surfactant dilution. So again, just taking a look at this diagram, remember that we have a fluid layer that coats the inner surface of the alveoli. And at the surface of fluid layers, we have this thing called surface tension, which is a force that causes the surface layer to contract, which is a collapsing force in the lungs. And so to decrease surface tension, we have these molecules coating the surface as well, called surfactant. And recall that surfactant decreases surface tension. It decreases the collapsing force in the lungs. Now, if we have a lot of fluid that's being collected in the alveoli, this is actually going to dilute the surfactant that's there. So the surfactant will be more spread out, and some of the surfactant will actually be washed away. And so because we're getting surfactant dilution, we're going to have an increase in the surface tension of the lungs, and this is going to decrease the lung compliance, and this usually will present in the patient as dyspnea. So on that note, let's go over the presentation of pulmonary edema. So oftentimes, because of gravity, when we have pulmonary edema, a lot of the fluid is actually going to collect in the basilar alveoli near the bottom of the lungs. And as a result, when the patient is breathing and we have air moving in and out of these basilar alveoli, it tends to create a bubbling or crackling or rail sound. And so a very classic description of pulmonary edema is bibasilar crackles and rails. Whenever you hear bibasilar crackles and rails, one of the first things you should think about is pulmonary edema. Now, like we mentioned, because pulmonary edema is usually caused by left heart failure, you can usually see associated left heart failure signs. So if left heart failure is present, then we can see things like an S3, which recall is an early diastolic heart sound that's associated with a more floppy, dilated heart, which can be seen in left heart failure. And you can kind of contrast this to an S4, which is a later diastolic heart sound that's more associated with a stiff ventricle or ventricular hypertrophy. And also recall that one of the main causes of right heart failure is left heart failure. So when you see left heart failure signs, you may also see right heart failure signs, such as increased jugular venous distension. So this is a very common constellation of findings that you'll oftentimes see together in question stems. They'll give you that the patient has a hard time breathing at nighttime. They'll give you that they have bibasilar crackles and rails and an S3, and you should be thinking, okay, this patient has left heart failure with pulmonary edema. Furthermore, we can also have dullness to percussion, and this is because when we have fluid in the alveoli and then you percuss the chest, it'll produce more of a dull sound because there's not as much air in the alveoli. And lastly, of course, like we mentioned, you can see dyspnea. And just taking a look at this X-ray image here, the X-ray findings for pulmonary edema are classically described as fluffy. So we can see these infiltrates are kind of fluffy like wool. And this is in contrast to things like pleural effusion or pneumonia, which is usually seen as a solid, opaque section of the lungs. And also pulmonary edema is a little more fluffy than things like ARDS, which is a complete whiteout of the lungs. And furthermore, we can differentiate this from things like lung cancer, which usually presents as a coin lesion or a mass. And we can see at the top of the lungs, we have these black spaces, which shows portions of the lungs that are uninvolved This is kind of in contrast to things like pulmonary fibrosis, where the x-ray findings look kind of similar, except for usually in pulmonary fibrosis, most of the lung is involved. One of the conditions that has x-ray findings that you may find a little bit difficult to differentiate between that and pulmonary edema is atypical pneumonia, because it also has bilateral patchy infiltrates. However, based off the history and the physical exam finding, like the bibasilar crackles and rails, the S3, or in the case of atypical pneumonia, a long-term or chronic fever, you can usually differentiate these. Okay, so now let's finish up by talking about the management of pulmonary edema. So one of the mainstay treatments of pulmonary edema is loop diuretics, because pulmonary edema is usually caused by high volume states, like we said, left heart failure. So as we know, loop diuretics cause profound diuresis, and as a result, this is going to decrease the blood pressure and decrease the intravascular volume, and thus the hydrostatic pressure in the pulmonary capillaries, and start to decrease the pulmonary edema. Another management that sometimes pops up in questions is positive end expiratory pressure, or PEEP. So essentially, one of the ways that you can think about PEEP, or positive end expiratory pressure, is the patient is breathing out of a ventilator, but the air that they're breathing is pressurized, so there's going to be high pressures in the alveoli. So if we just take a look at this diagram at the bottom of the screen here, recall that we have the alveoli in close relation to the pulmonary capillaries, but also they're in close relation to these pulmonary lymphatic vessels here. And so when we have fluid that has collected in the alveoli, if we increase the air pressure within the alveoli through positive end expiratory pressure, this is actually going to push the fluid into the lymphatic vessels, and the fluid will start to drain from the alveoli into the lymphatics. And so as a result, these high air pressures will be pushing the fluid and draining the fluid into the lymphatic vessels here. And we just have that in the text here. The positive end expiratory pressure is going to increase the alveolar pressures, which is going to push alveolar fluid into the lymphatics and enhance the drainage of the alveolar fluid. All right, and that's all we got for our video on pulmonary edema.